am Dr. Arun. I am working as a consultant radiologist in Vijaya Diagnostics, Habsiguda. I welcome you all to today's Vijaya Diagnostic webinar series. Today's topic for discussion is Decoding O-RADS, a comprehensive approach to Adnexal mass characterization and risk stratification. Today's chief guest is Dr. K. Shilpi Reddy ma'am. Good evening, ma'am. I would like to have a brief introduction regarding her. Dr. K. Shilpi Reddy madam is working as a clinical director and head of the department, Obstetrics Gynaecology department in KIMS Cuddles, Kondapur. Apart from her academic excellence, she is also a very good social activist, woman entrepreneur, philanthropist, motivational speaker, and author, and with a vision for women's empowerment. She has done her M.B.B.S from MRMC Gulbarga, following which she did her D.N.B. Obstetrics from Yashoda, and she has been exclusively trained in laparoscopy. And she has got a lot of accreditations towards her. She is also having a foundation to target and successfully complete other campaigns related to women's health, care, and empowering the women in society and transforming their lives in a better way. She is also involved in a lot of health camps for women in AP and Telangana. I welcome you on the dais, ma'am. Nextly, I would like to introduce about today's speaker, that is Dr. K. Rohini Reddy. She did her M.B.B.S and M.D. from Chalmada, Andhra, Karimnagar, following which she did her fellowship in onco-imaging training from Tata, Calcutta. And she is working as a radiologist with us at Kavuri Hills branch. I welcome you on board. So I would know, so you can carry on with your presentation.
Sure, sir. Good evening, everyone. Good evening, ma'am. Good evening, sir. I will share my screen now.
Yeah.
Okay. So today's topic is Decoding O-RADS, which is a comprehensive approach to adnexal lesions and the risk stratification. Okay. So O-RADS, which is used for the standardized description and classification of the lesions. There are two main arms in the O-RADS, which is ultrasound and MRI categories. Ultrasound is considered as a first-line imaging modality for evaluation of the adnexal lesions. The risk stratification is based upon the sonographic features to predict the risk of malignancy and guidance on the management. It was developed by the International Multidisciplinary Committee by the American College of Radiology. So here in this presentation, we will be discussing regarding the O-RADS in the ultrasound. So the main concept for the O-RADS ultrasound is we have to consider the menopausal status, which is relevant for risk stratification or management of a patient. So it is categorized as pre or post-menopausal. Post-menopausal category is defined as an amenorrhea greater than 1 year of duration. Here we have early menopause, early post-menopausal, and late. Early is less than 5 years of duration and late is greater than or equal to 5 years of duration. If we are uncertain or regarding the uterus, any surgical status, then we will manage as per the postmenopausal status if the age of the patient is greater than 50 years. O-RADS applies to the lesions involving the ovaries or fallopian tubes. If a pelvic lesion origin is indeterminate but suspected to be a ovarian or fallopian tube, then O-RADS is applicable. In case of absent ovaries like surgical status, then O-RADS is not applicable. In case of multiple or bilateral lesions are present, each lesion should be separately characterized and management will be done by the lesion with the highest score. But the separate recommendations must be provided when the management of one lesion is independent of the other lesion. If pelvic lesion is clearly identified and it is considered as not an ovarian or tubal origin, then it is applicable only in the 3 conditions, that is para-ovarian cyst, peritoneal inclusion cyst, and hydrosalpinx, benign extra-ovarian lesions. The management recommendations are based upon the average risk of a patient and not considering the acute symptoms. Individual case management and judgment can be modified by risk. For example, if the patient is having personal or family history of ovarian cancer or BRCA mutations, any other clinical factors, that it can vary depending upon the professional judgment. The single largest diameter of the lesion is used for the risk stratification. and management. But when reporting, 3 dimensions is helpful to assess the interval change and interval change in the follow-up scans. The risk stratification methodology in the ultrasound. We have total 6 categories. Category 0, 1 to 5. So category 0 is incomplete evaluation, like similar to the BI-RADS, where the complete evaluation should be done. I will describe briefly in the next slides. The main lexicon terms in the O-RADS we use are follicle. Follicle is like a simple cyst less than 3 centimeters in the premenopausal group. Corpus luteum is a thick-walled cyst less than or equal to 3 centimeters in size with crenulated margins. The another terms we predominantly use in the O-RADS is unilocular, multilocular, and bilocular cyst. Whether with the solid component or without solid component is the terms we will be using in the O-RADS. So when unilocular cyst with no solid component means it is a cystic lesion with the incomplete septum, echoes may be present, which is a non-simple. Unilocular cyst with solid component describes as a solid component greater than 3 mm in the height. Multilocular cyst with no solid component, which is a cystic lesion with more than 2 compartments, and bilocular cyst is a cystic lesion with more than 1 compartment, and at least more than or equal to 2 septum will be present. When solid component, multilocular cyst with solid component is greater than 1 solid component greater than 3 mm in the height. Next is solid or solid appearing lesions. Here, the lesion is described as solid when its echogenicity is suggestive of a tissue without any characteristics of a cyst. The lesion should be at least 80% of a solid, and this can be confirmed with a color or spectral Doppler. The maximum diameter of the lesion is considered for the O-RADS score calculation. When we are talking about the solid or solid appearing lesions, the most important thing to consider is the external contour of the lesion, whether it is smooth like regular outer margin or irregular, non-uniform outer margin or lobulated contour is also considered as an irregular margin. Second important thing is internal contents. If there is any shadowing, which is shadowing is an artifact produced by an attenuated echoes. So this is commonly used descriptor for any calcifications or fibromatous type of lesions. When we are talking about the bilocular or multilocular cystic lesions, we will be discussing more regarding the how is the inner margin or walls, including the solid component. First thing is a papillary projection or a nodule. Papillary projection is a solid component whose height is greater than 3 mm. If it is less than 3 mm, it is called as a wall irregularity. Papillary projection is something whose measurement should be greater than 3 mm and it is surrounded by the fluid on the 3 sides. Next one, how is the inner margin and walls? Whether it is regular or irregular need to be considered. And the content within the cystic component, whether it is anechoic without any internal echoes or hyperechoic component, which is an area of increased echogenicity within the cystic cavity, which is used to describe the dermoid, hemorrhagic lesions, any calcifications. The most another important category to be used for assessing the O-RADS is the color score. Here, color Doppler or power Doppler is necessary to describe the vascularity of the lesion. The velocity to be maintained is 3 to 6. And we have to adjust the Doppler gain just below the artifact level. So this is overall a subjective assessment. This is the where there is color score 1 is no flow within the lesion. Color score 2 is a minimal flow within the lesion, septa, wall, solid component. Color score 3 is a moderate flow. And color score 4 is a very strong flow within the lesion. So color score 1 to 4 is used from the O-RADS 3 to 5. There are few. O-RADS was first described in 2019 and the updates of lexicon terminology was done in the 2022. Here, initially it was unilocular and multilocular cystic lesion, but the new update is a bilocular cystic lesion. Previously, O-RADS was limited to the characterization of lesions as unilocular or multilocular cyst. Now, bilocular cyst with one complete septation is described. So this is one simple unilocular cyst with no septations. Bilocular cyst will have 2 locules and 1 septations, complete septations. Multilocular cyst will have more than or equal to 3 locules and at least 2 or greater than 2 complete septations will be present in the multilocular cyst. Another important thing which I described prior is shadowing for a solid lesions, which is a hypoechogenicity seen posterior to a lesion due to an attenuation of the beam. So there are broad and diffuse shadowing, which is a descriptive for solid and solid appearing lesions. So this is the diffuse shadowing and this is a broad shadowing. So here we will be start describing what are the categories of the ORADs. The first one is ORAD 0. ORAD 0 is an incomplete evaluation due to technical factors such as bowel gas, larger size of the lesion, and location of the adnexal, inability to tolerate the transvaginal imaging. In such cases, we either advise a repeat imaging or alternating imaging is advised. Next category is category 1, which is a normal ovary less than 0 to less than 1% likelihood of a malignancy. This is a physiological category relevant only in the premenopausal patients. Here, it applies only in premenopausal. First thing is a follicle. Follicle is a unilocular cyst, anechoic cyst, which is less than 3 centimeters. Second is the corpus luteum, which is a thick-walled cyst less than 3 centimeters with crenulated margins and internal echoes will be present. And on color Doppler, peripheral vascularity is seen. In some cases, the corpus luteum can be seen as a hypoechoic region within the ovary, but peripheral flow will be present. So it is recommended that it is described as either follicle or corpus luteum rather than a cyst. So this is the typical corpus luteum where there is a thick-walled cyst with crenulated margins and fine internal echoes and peripheral vascularity is seen. And this is another case where there is a hypoechoic region within the ovary, but peripheral vascularity is present. This is one of the case of a corpus luteal cyst. Corpus luteum. Next category is category 2 ORADS 2, which is almost certainly benign category, less than 1% risk of malignancy. Here the main important is measurement. It should be less than 10 centimeter in the maximum diameter. In category 2, color score is not included in the evaluation of lesions in this category. This category includes simple cyst, non-simple unilocular cyst with a smooth wall and classic benign lesions. So first is a simple cyst. Simple cyst is something size greater than 3 centimeters but less than 10 centimeters in the premenopausal woman and less than 10 centimeters in the postmenopausal woman, which is a smooth wall, no internal echoes, no irregular septa will be seen. Simple unilocular cyst. Another term we use is a non-simple unilocular cyst with a smooth inner margin and less than 10 centimeters. Here, non-simple is the term applied when there are internal echoes or incomplete septa. This incomplete septa is not considered as wall irregularity. Bilocular cyst with a smooth inner walls less than 10 centimeters. It can be either simple or non-simple, having an echoes or a septa. There are another lesions like typical benign ovarian lesions less than 10 centimeters falls under the category 2. Typical benign extra ovarian lesions like para-ovarian cyst, hydrosalpinx, peritoneal inclusion cysts, they come under the category of ORADS 2 irrespective of size. Any size will fall under the ORADS 2. So classical benign lesions are typical hemorrhagic cyst, dermoid cyst, endometrioma less than 10 centimeters will fall under the category 2. Para-ovarian cyst, peritoneal inclusion cyst, hydrosalpinx, any size is ORADS 2. So here I will be describing briefly regarding the benign lesions and also their respective management. So first one is a typical hemorrhagic cyst, less than 10 centimeters. It is a unilocular cyst, no vascularity, at least one of the following. That is a reticular pattern, fine thin intersecting lines representing the fibrin strands like a fishnet pattern. Sorry. Another one is a retractile clot, which is an intracystic component. These are main two descriptors for the hemorrhagic ovarian cyst. When we are speaking regarding the management of this category, in the premenopausal woman, if the size is less than 5 centimeters, Nothing. Usually it will resolve spontaneously in 1 or 2 cycles. But if it is greater than 5 and less than 10 centimeters, we will advise a follow-up in 2 to 3 months of duration, that is 8 to 12 weeks. In early postmenopausal, that is less than 5 years of postmenopause, if it is less than 10 centimeters, we might advise a follow-up in 8 to 12 weeks, or any advise MRI if for MRI scoring, or ultrasound specialist. In the late menopause, usually hemorrhagic ovarian cyst should not occur. So we will use the descriptive terms to upscore into the another category. Typical dermoid cyst. It is also comes under the category 2, less than 10 centimeters. It is a cystic lesion with less than or equal to 3 locules, no internal vascularity, which is showing a hyperechoic component with diffuse or regional shadowing will be present, hyperechoic lines and dot and dash pattern, and floating echogenic spherical structures will be seen. So this is typical dermoid cyst. Here in the imaging, if it is less than 3 centimeters, we may consider follow-up in 12 months of duration. But if it is greater than 3 and less than 10 centimeters, if not surgically excised, then we will advise a follow-up in 12 months of a duration. This is case of a dermoid cyst, which shows a well-defined lesion within the right adnexa, showing a densely packed echogenic content with a hyperechoic dot and line and dot pattern, dot and dash pattern. Typical endometrioma, which is less than 10 centimeters, falls under the category 2. No internal vascularity, homogeneous low level or ground glass echoes will be seen with smooth inner walls. Sometimes, rarely, we can see peripheral punctate echogenic foci in the wall. The management of endometrioma in the premenopausal woman, if it is less than 10, if not surgically excised, we keep a follow-up like a dermoid 12 months follow-up. In the postmenopausal, follow-up in 8 to 12 weeks is only advised, or else ultrasound again or MRI for ORAD score. If surgically not excised in the postmenopausal, again post 8 to 12 weeks, we will re-follow up the scan, follow-up scan in the 12 months of duration. If it is stable, again follow-up ultrasound in the 24 months. There is one study which mentions that there is an increased risk of malignancy if endometriomas are seen in following the menopause and they are present stable for about 10 years duration also, there is increased risk of malignancy like endometrioid carcinoma and clear cell carcinoma. The other typical benign extra ovarian lesions are simple para-ovarian cyst, any size, peritoneal inclusion cyst, surgical history is to be known, and typical hydrosalpinx. So para-ovarian cyst is seen separately from the ovary. Typical peritoneal inclusion cyst may have a suspended ovary within the lesion or at the margin of the cystic lesion. Hydrosalpinx is a anechoic tubular structure with incomplete septations, and endosalpingeal folds may be noted. So when management of these lesions, typical para-ovarian cyst, if it is asymptomatic, then conservative management is done. If there is a risk of a torsion, then they will go for a surgery. Typical peritoneal inclusion and hydrosalpinx also, if asymptomatic, then conservative management is done. Typical peritoneal inclusion cyst will have an ovary at margin or suspended within the ovary. Septations may be present. Typical hydrosalpinx is anechoic fluid-filled tubular structure with incomplete septations, and endosalpingeal folds may or may not be seen. This is one of the case where it shows a tubular anechoic structure within the adnexa with septations is seen. Category 3, which is a low risk category. It is 1% to less than 10% risk of malignancy. It's almost certainly benign lesions greater than 10 centimeters falls under this category, and multilocular cyst less than 10 centimeters with no solid component, smooth inner wall, and color score 1, 2, 3 falls under category 3. Solid or solid appearing lesions, smooth outer counter, any size, color score 1, and unilocular cyst, any size with wall irregularity, that is less than 3 mm height, ORADS 3. Here color score is included in evaluation of a lesion. And low risk category is 1% to less than 10% risk of malignancy. So first, typical benign ovarian lesions as described prior, greater than or equal to 10 centimeters will fall under 3. Unilocular or bilocular cyst greater than 10 centimeters. Unilocular cyst with irregular inner wall. The irregularity of the inner wall measuring less than 3 mm in height. Any size, any color, any size falls under the category ORADS 3. Focal thickening less than 3 mm. This is one well-defined anechoic cystic lesion greater than 10 centimeters. So falls under the category 3. Multilocular cyst with the smooth inner walls and septations less than 10 centimeters, color score 1 to 3, either no, minimal, moderate flow, falls under the category ORADS 3. Solid lesion either with or without shadowing, smooth outer contour and color score 1 is ORADS 3, which is the solid lesion should have at least greater than or equal to 80% solid component. Solid lesion with the shadowing, smooth outer contour, color score 2 to 3 will be ORADS 3. Category 4 is a risk of 10% to less than 50% risk of malignancy. Here we include multilocular cyst greater than 10 centimeters, smooth inner wall, color score 1 to 3. If it is less than 10, it is ORADS 3. If it is greater than 10, then it is ORADS 4 without solid component. Multilocular cyst, any size, smooth wall, but color score is 4, then it is ORADS 4. Multilocular cyst, any size, but irregular inner wall and septal irregularity, any color score is ORADS 4. Unilocular cyst with solid component with wall irregularities ORADS 3, but with solid component, that is a papillary projection 0 to 3 papillary projections is considered as ORADS 4 irrespective of size and color score. Multilocular cyst with solid component any size, color score 1 to 2 is ORADS 4. Solid component, smooth contour, any size with non-shadowing is ORADS 4. So this is a bilocular and multilocular cystic lesion without solid component showing an irregular inner wall and irregular septa is present. So here there can be any size, any color score. Multilocular cyst with a smooth inner wall and septations but greater than 10 centimeters but CS less than 4, color score less than 4 is 4 category. Same multilocular cyst with the CS color score is 4, that is strong flow, then it is ORADS 4. Unilocular cyst with papillary projections, which is greater than 3 mm in height, surrounded by fluid on all the 3 sides, and 0 to 3 is the number of papillary projections included in the ORADS 4 category, irrespective of a size and color score. Multilocular cyst with solid component, any size, any color flow score is considered. Unilocular cyst with solid component, any size, any color score is considered as ORADS 4. Multilocular cyst with solid component, color score only 1 to 2 is considered as a ORADS 4. And next is solid lesion with the non-shadowing and smooth outer counter, color score 2 to 3 is considered as a ORADS 4 category. Here, this is one of the cystic lesion with solid component noted, but here color score can be given up to 1 to 2. So here 2. So here it is a ORADS 4. But when we are considering here it can be CS to the 4. So 3. In this condition, we can upgrade it to the ORADS 5. ORADS 5 is a high risk category greater than 50% risk of malignancy. Here, unilocular cyst with any size greater than 4 papillary projections, color score anything, it is considered as 5. Multilocular cyst with a solid component, any size and color score 3 to 4 is considered as ORADS 5. Solid lesion, smooth outer counter, color score 4, and when outer counter is irregular, irrespective of size, irrespective of color score, it is considered as ORADS 5 when solid lesion is showing irregular counter. And another features like presence of ascites, peritoneal or omental deposits is a ORADS 5. So unilocular cyst with greater than or equal to 4 papillary projections, any size, any score. Multilocular cyst or bilocular cyst with solid component, any size, color score 3 to 4. Solid lesion, smooth counter, color score 4, any size is O-RADS 5. But solid lesion, any size irrespective of color score, if outer counter is irregular, it is O-RADS 5. And another feature is ascites and peritoneal deposits. But when there is association with, we have to consider any other pathologies for ascites need to be ruled out, like cirrhosis, etc. This is one of the solid cystic lesion present within the adnexal region, shows an thick echogenic ascites, free floating bowel loops, and thick irregular nodular peritoneal thickening noted, which is categorized as O-RADS 5. Management of the O-RADS. So once categorization done, we have to categorize which lesions require a follow-up or conservative, no follow-up, conservative follow-up, and consultation with gynecologist or gyneco-oncologist. So first category 0 is incomplete evaluation. So first repeat the study or advise an alternate study. Category 1 comes under the normal ovary, which is not applicable in the postmenopausal woman. Here includes follicle and corpus luteum. Nothing, no management. Category 2 is almost certainly benign lesions, less than 1% malignancy. Here it includes the simple cyst. If it is less than 3 centimeters, it is not applicable in the premenopausal. But simple cyst, if it is greater than 3, up to 5 centimeters, in premenopausal, nothing to be done. But in postmenopausal women, if the cyst size is greater than 3 and less than 10 centimeters, we will advise a follow-up ultrasound in 12 months of duration to check any other nodularity, septations are present, or is it stable. Whether in the premenopausal woman, if it is greater than 5 centimeters but less than 10 centimeters, we will follow up ultrasound in the 12 months. In the premenopausal, it should be at least greater than 5 for a follow-up. When we are talking about the unilocular or bilocular smooth cyst, whether it can non-simple cyst, if it is less than 3 centimeters, in the postmenopausal, we will advise a follow-up in the 12 months of duration. In the premenopause, no. And if it is greater than 3, less than 10, for both pre and post menopause, we will advise a follow-up in 6 months of duration. As I discussed prior regarding the management of the typical benign and extra ovarian lesions. Low risk category, which is 1% to less than 10% risk of malignancy, which includes typical benign ovarian lesions, unilocular, multilocular cyst with a size greater than 10 centimeters, but multilocular cyst size less than 10 centimeters, and solid lesions with CS 1 to 3 only. In this imaging, if it is surgically not excised, then we will consider a follow-up in 6 months of duration, because this O-RADS 3 sometimes it is considered as a gray zone. So sometimes the follow-up can be managed to the 2 to 3 months also to check for any septations, nodules, solid component. If it is a solid, we will consider an repeat ultrasound or MRI, because solid component shows a enhancement which is a specificity of an MRI for MRI scoring. Category 4 is an intermediate risk, which includes 10 to less than 50% risk. This is a bilocular cyst with solid component or unilocular cyst with papillary projections less than 4 and multilocular cyst greater than 10 centimeters, solid lesions with a CS 2 to 3. In these conditions, we include options include either ultrasound specialist or MRI for MRI scoring, or gynecologist or gyno-oncology protocol will be used. If any family history, as discussed prior, if there are individual risk factors like family history prior, then here we can go for the oncology referral. Category 5 is a high risk category, which includes greater than or equal to 50%. Here unilocular cyst greater than 4, papillary greater than or equal to 4 papillary projections, solid multilocular cystic lesion with solid component showing color score 3 to 4, solid lesion with irregular counter, ascites, peritoneal nodules. If all this included, then we will refer to the gyneco-oncology protocol, like a staging protocol will be followed. The main important points in the ORADS is standardized description. We always describe these ovarian lesions with the ORADS terminology. Risk stratification is the core. Menopausal status matter because if the same cyst can be benign in the premenopausal woman, but it is suspicious in the postmenopausal woman. Sometimes ORADS 3 can be a gray zone which requires a short-term follow-up. ORADS 4 and 5 requires a gynecologist or oncologist referral in immediate basis. Management recommendations should serve as a guidance based upon the average risk with no acute symptoms, but individual case management can be modified by risk based upon their family history, professional judgment, BRCA mutations, or any acute symptoms. Thank you.
Thank you, Dr. Rohini. That was an extensive and wonderful presentation.
Thank you.
Now the forum is open for discussion. Firstly, I would like to request our chief guest of today's session, Dr. Shilpi Reddy Madam, to show what are the clinical implications and utilization of this ORADS in daily clinical practice in her regular day-to-day routine practice.
Hello all, I am Dr. Shilpi Reddy, and ORADS is a very, it brings uniformity amongst classification of problems. And if somebody practices ORADS on a regular basis, and we will not have to hunt for, diagnosis, and it's self-explanatory. Okay, when you look at the report and it is ORADS 1, you can really assure the patient who is very tensed that I have something of 3 centimeters. How is it not different from cancer? You can always tell them you can be relaxed. And something that is ORADS 4 or 5, how to define the seriousness in this situation is already there. And it is easy for us to explain to them and make them understand the implications. And once every radiologist follows ORADS, there will be no difference of opinion. That's more important because one gives one report and the other gives another report. There is a huge difference in terms of classification, understanding, explanation, and every obstetrician or a surgeon interprets their own findings their own way. Rather than that, if we follow ORADS, then it's a medico legal clinical interpretation of any problem, and the simpler you make it, you will be more closer to diagnosis, which ones to watch for, which ones to wait for, which ones to enact upon, and which ones are an immediate action takers is something that is of immense value. And there has always been a point of interest that there are associations and credibilities and interest created for the comfort of clinicians. And every tool that is designed, whether it is a medical tool or whether it is a informative tool or whether it is a diagnostic tool, it is in the interest of the clinicians and to simplify their treatment protocols, and more so patient friendly and doctor friendly. So here ORADS is something that is going to define the treatment protocols and also make diagnosis simple and treatment clear, so that we will stand on one uniformity, one protocol. And uh, it to an extent that it will also take away the fear, because there is always a gap. I stay in a corporate hospital where we have access to radiological tools, but when patient goes outside, gets a report from the diagnostic center, the patient has to take appointment from the doctor and the next day goes to the doctor, and the patient has to talk to the doctor before the confirmation comes. How do they even understand the report? If it is given in ORADS, okay, the patient also has an understanding, okay, this is not very bad, or this needs a certain attention at the current scenario. So it's important, and it's also important to document every report by ORADS. Still, there is so much a need of uniformity of reporting at every place.
Thank you very much for your insights, ma'am. If anybody has any questions, they can ask. I had actually one query, Dr. Rohini. If there is a multilocular cystic lesion with no solid component or anything, whether it will fit it into O-RADS 3 or 4?
Depending upon the size, sir. If multilocular
Right, 10
cystic lesion
centimeter.
with smooth walls and smooth septa less than 10 centimeters comes under the category ORADS 3. If it is greater than 10 centimeters with smooth walls, it comes under the category 4. But if there is irregular wall, irregular septa, irrespective of size, it comes under the category 4.
Yeah, one more query. If the patient comes in follow-up, and can the O-RADS be upgraded or downgraded?
Yes, sir. If depending, if the lesion which we have seen in the prior scan, is showing any new septa, new solid component or subtle wall irregularity, it's better we upscore the ORADS, because as we all know, ovarian malignancy is highly lethal. So when it is treated aggressively, it can give time to the patient.
If no more questions, I think, ma'am, do you have any other questions?
No, I'm fine.
Yeah. Thank you all for your participation, and thank you, Dr. Shilpi ma'am and Dr. Rohini, for your contribution. And I close this forum now.
Thank you, Shilpi ma'am. Thank you, sir. Thank you, Vijaya sir, for giving me this great opportunity. Thank you.